as we think a bit together about why we're discussing all of these topics today and why we're thinking together about empower is that, as with many cancers, but arguably, as I noted, perhaps even more so with myeloma, race does matter in myeloma care and survival. And our objective is to change the course of myeloma. And that's not just a cute little tagline. That really is something we can do. And it's going to take people like those who are in this room, people who are patients, people who are care partners, people from industry, people from the community, people from fraternities, sororities, churches. I think of all the places that we go to, barbershops, the National Medical Association, the Black Nurses Association. You're going to hear about all the people we're trying to bring together to overcome this, to indeed change the course of myeloma. But what is that course of myeloma? Well, we've mentioned some of these facts already, but let me just give you the top 10 facts so that you know the numbers. Number one, myeloma is the most common blood cancer in African Americans. We talked a little bit about that already, how common it is. And it's common because it is twice. The incidence is twice as high in those of African descent. Now, for clarity today, and again, most of us would be familiar with this, we don't necessarily use the terms African American and Black interchangeably. They're not entirely synonymous. I tend to use the word African American when we're discussing biology and heritage. So I use myself as the example. I'm African American, but if you look at me, you wouldn't think I'm Black necessarily. My heritage is from Egypt, which is a country in Africa that has that high genetic risk of myeloma, but I may not have the appearance that someone might think of someone who's Black. And so some people may identify as African Americans, some prefer to think of themselves as Caribbean Americans or have an origin in the Caribbean, not necessarily in Africa. But nonetheless, they're not exactly overlapping, but of course there's a lot of overlap between the two. And so from a pure, if you will, biological standpoint, we don't fully understand it. We're doing a lot of studies trying to appreciate this. And we've gone to places, we've done studies in Ghana, in Ethiopia, and Kenya, and other countries where we have seen this higher incidence of the disease. Not only is it more common, it's actually diagnosed at a younger age. And this is actually going to be important when we come to what I'm going to summarize as the major drivers of health disparities, that one of them is going to be a delayed diagnosis. And part of it is when we went to med school, you kind of get taught that myeloma is a disease of old people, right? That the average age of diagnosis is pretty much 70, and yet we come to appreciate the fact that there are a lot of younger patients with myeloma. I've actually had particular interest in understanding myeloma in the very young. In fact, on average, the youngest patients diagnosed with myeloma are patients of Hispanic origin. In fact, I traveled once to Uruguay to meet the youngest person that we know of, at least, who's ever diagnosed with myeloma, a young 8-year-old boy that I had the privilege of meeting. And so you can see here that on average, the age of diagnosis of Hispanic Americans would be 65, 66 for African Americans, but for Caucasian white patients, it's about 71. So there is a difference there as we see it in the age of diagnosis. So when you think of the population then, so right now, about 13.6 or 14% of people in this country are of African descent. 20% of all myeloma patients are African American. So you think about it, that's 1 in 5. And that number, remember that, because we're going to come back to that number a little bit later when we start thinking about it. And I know this curve is not really easy to follow, but that's why I've tried to circle the numbers on the side of it. But this talks to us about what's the life expectancy of individuals who have myeloma. And there's a vast difference, as I've mentioned, whether it's men or women or everyone together, between African American patients, Black patients, and white patients. The average survival is half as long for Black patients. Part of this is related to, and I intimated this earlier, that delayed diagnosis. So because patients don't come in saying, "Hi, I've got myeloma," right? They've got this back pain that's been getting worse and worse. And I know many of you can tell your story about how, I went to the chiropractor, it didn't get better. I took some ibuprofen, it didn't get better. And eventually we figure out they have myeloma. So for most patients, there's several month gap, if you will, between the initiation of their vague symptoms that's hard to identify as myeloma and truly have myeloma. There are some exceptions to the rule. There's some people who get myeloma detected because they're getting life insurance blood work, and someone says, "Wait a minute, There's some high proteins in your blood and they catch it before it's caused damage. But for most people, there's that gap. We know that within African American patients and indeed Hispanic American patients, obviously our focus today is within the African American community, but we want to care for all patients with myeloma. That time is delayed. It's even more so, somewhere in the range of 3 to 6 months longer. And you say, well, why is that? Well, there's lots of different reasons. One of it is what we call confounding diagnoses, meaning those symptoms I was sharing with you that people have myeloma often are actually very similar to the ones we see from diabetes. And so it's very unfortunate that a lot of our patients are ultimately diagnosed with myeloma. They look back and say, for all those months, my doctor told me that my anemia or that my kidney damage or that protein in my urine or even that neuropathy, that numbness I was feeling in my hands and my feet was all related to the diabetes, when in fact, it was actually myeloma brewing. And you can have two diagnoses at the same time. Very importantly, there's lack of access to diagnostics and care. We know that within certain populations, there's less likely to have a primary care doctor, more likely to be on Medicaid or Medicare and systems that may not have as much access. We'll come to the healthcare system in a minute. The lack of awareness of those primary care providers. I'm not trying to pick on the family docs today. They got so much to do and so much to cover, but they see back pain. They don't really think or register of myeloma. But if we make them aware that, here's a population that's twice at risk, and maybe you have that person come in with back pain. Oh, and by the way, they're also a little bit anemic. We need to make that connection. So that's why you'll see a lot of our work in Empower is designed to educate primary care doctors about myeloma. And then a timely referral to specialists, because ultimately this is a disease that is cared for by hematologists, oncologists. We're going to be talking a bit later about trying to connect with a true myeloma doctor in addition to that, but even just access to hematology oncology is reduced. And a lot of that, as I don't have time to go into incredible detail around it, but we know has a lot to do with the healthcare system, has a lot to do with systemic racism, social determinants of health, and other drivers that we're going to come to in a little bit. Number 7, African Americans are less likely to receive the critical treatments. So I'm actually going to talk about 4 T's, but I put 3 on this one. I use the letter T because they all start with the letter T. So we've learned over the years, these 3 things have actually significantly improved survival in myeloma. What are called triplets, or 3 drug combinations that we use together. Transplants, or autologous stem cell transplants, and Yelek was showing that picture of him having his stem cells collected. And then more recently, this amazing therapy called CAR T-cell therapy that Shane's going to share with you a little bit more. And sadly, we know for all 3, as an African-American patient, you're less likely to have access to those 3. So it's sadly not a surprise that we see that reduced survival. The other 4th T that sometimes, of course, raises angst, and appropriately so, and we should discuss this very openly and honestly, are clinical trials. There's been a history in this country and in others of mistreatment of individuals on the basis of clinical trials. On the other hand, we know that clinical trials can actually significantly improve an individual patient's and a group of patients' outcomes. And so we have to look at this. So remember, I mentioned that African Americans have comprised about 20% of all myeloma patients. This is the most bold of the estimates. In fact, it's probably more like 3 to 4%, but an average representation is less than 10, if not less than 8%. And that causes a whole series of challenges, that people don't have access to it, that all these new drugs that we talk about, we don't really know, to be blunt, how well it works in certain populations, within the Hispanic population, the African American population, and if there are unique, what we call toxicities. And we're going to learn a little bit about that because we're starting to see that with these new treatments that we're using, that there may be differing levels of some of the side effects that people have based on their race and their ethnicity. I mentioned that there are 10 of them, so we're almost there. Number 9, there are what we call biological differences. Now, again, this is more for people who are already into myeloma. This looks like a bit of an alphabet soup here. But when we test those plasma cells out of the bone marrow that I described, we also look at the genetics of them, because myeloma has a big spectrum, and sometimes we put people into 2 buckets, what we call high-risk myeloma and standard-risk myeloma, based on how aggressive those genetics are. I tell patients it's how much horsepower the myeloma has, that it has that ability to grow quickly and to come back quickly. And so someone might say, well, maybe African Americans don't do as well with myeloma because maybe they're more likely to have the aggressive form of myeloma, the high-risk form of myeloma. And actually, the opposite is true. That an African American patient is more likely to have standard risk myeloma than they are to have high risk. So for me, this widens the disparity because it tells you that you would think that African Americans actually should do better with myeloma by virtue of a less aggressive, if you will, biology, but that's not the case. However, number 10 is maybe the most encouraging of them to me, which is now we're looking at, I know these curves may be challenging to understand, let me simplify them, that when we look at large studies like, for example, like the VA, or at least theoretically in the Veterans Affairs system, everyone gets the same access to treatment independent of race or ethnicity. If you look at the outcomes within the VA system, African Americans live longer with myeloma than Hispanic Americans and indeed white Americans as well. So it tells us that if we give the right therapies, if we give access, that we can help overcome this disparity. So I know that's a lot of information, but what can we do about this? Well, as I mentioned, this is complicated. This is not just about myeloma, right? There are many systemic drivers of this problem that I could, and I give lots of talks on health disparities, and we could discuss this, at length, that there are so many things that we could discuss about, how systemic racism influences outcomes, the healthcare system and its design, the social determinants of health. As we often say, it's one thing to say, oh yeah, I want to give this patient a clinical trial, but if there isn't food on the table to feed that patient and their family, they're not going to get to the cancer center for the clinical trial. But then, as we think of the complexity of that, we've tried to simplify it a little bit here and say that the themes of success are going to be in the lay community, in the medical community, as well as in the regulatory and the corporate community. That we need everyone to work together towards this. And I know it sounds like, okay, let's all hold hands and sing Kumbaya. It's not that simple, right? It's very complicated in the way we approach it. But we do think that we can chip away at this. And it's not about saying we can fix health equity by tomorrow, but it means we have to have an imperative for tomorrow, but we also have to have a long-term strategy and plan. And so that's why we created Empower. So Empower is a bit of a play on words. It stands for myeloma power. And as I mentioned, we're here to empower patients and communities to change the course of myeloma. Because hopefully, even if you've been napping and you think, oh, when is he done so I can get a second cup of coffee? Hopefully you have figured out that there is, yeah, I love you too, Ken. Hopefully that we've come to appreciate that this course is not acceptable. So to keep it simple, we're doing 3 things that all start with the letter E. There are 3 arms to empower. The first is to engage, and hopefully that's what we're doing today. We want to engage the community, and we will partner with anybody and everybody to do it. And that's why, as I mentioned, we've done these programs in churches and community centers, and now fraternities, working in any opportunity we can to raise awareness around myeloma so people know the signs and symptoms. I'm not here to freak people out and say, go run to your doctor. It was interesting. I'll give you a little preview. You're going to see an interesting video in a few minutes from someone who's relatively famous. Rhymes with mice tea. Anyway, I was talking to him about this, and he said, Dr. Joe, here's my arm. Do you need to take my blood right away? And I didn't want to, I don't want to ever scare anybody and saying myeloma is at your door. I'm not trying to scare people. But on the other hand, we want to raise awareness so that people know. So when that fatigue really is not explained, when your doctor tells you have anemia, when you have back and bone pain that goes beyond what is typical for back pain, that you talk to your doctor about it, that you know how this affects your community, so that you can support your community in the best way possible. Engage. Number 2 is to educate. And we're focusing on the primary care doctors, as we've mentioned, because those are the ones, that's where the starting point of diagnosis is. So if part of the disparity in myeloma is the delayed diagnosis, we want to shorten the time to diagnosis by educating our primary care friends about not only to think about the signs and symptoms of myeloma, but what are the right blood tests. There's about 3 or 4 blood tests that have to be done. One of the things that some people feel really comfortable, they go to their annual visit and their physical and they get some blood tests and they feel like everything's good. It's kind of like when maybe the mechanic looks at your car and says, yeah, you're good. But your mechanic doesn't look at every single thing in your car. That blood test doesn't cover everything, and the tests that we need to do for myeloma are different tests. And then lastly, to enhance. And what do we mean by that? We want to enhance the care delivered to those patients who have myeloma by working through the whole healthcare team. We're going to hear from Beth in a few minutes about the role of the nurse, physicians. Thinking long term, I'm going to share with you in my last couple of minutes now a program where we're engaging minority medical students, many from historical black colleges and universities, to learn about myeloma and health disparities so that we can build a deep bench in the long term to overcome this and provide that. So Empower is both a national movement and a local movement. We've been working in multiple cities. We started in Charlotte. We've been in Atlanta, in Baltimore, in New York, obviously now in Tampa. In a little over a month, we're going to be in Detroit, and we've already making our plans for other places next year. And the idea here, as I've mentioned, is to put the patient in the middle and surround them with all of these individuals and resources. Everybody and anybody who's willing to partner with us, we can do it. We did a lot of this during the pandemic, of course, and even now. And so we've created this Empower website. You can go to empower.myeloma.org, where we have a huge toolkit of resources for people so they can learn the symptoms. They can get financial assistance and aid and information about that if they are going through it, where they can see that. We can watch videos of individuals like Yellick and others who have been through this journey. We try to use different creative formats. You can see here I've created a video series. We've worked with others. For those who are hip-hop fans, you see Dougie Fresh there. We even did a program with him to try and raise awareness. As I mentioned, we had a program at the Riverside Church, and we simulcast to Grace Baptist Church in Mount Vernon. So we were in Harlem on the Juneteenth weekend for a program like this. And then in just about 6 weeks from now, in the first week of November, we will be in Detroit, as you can see here, at the Tabernacle Missionary Baptist Church for another program for Empower. I've already gone into a little bit of detail about telling you about how we educate primary care physicians, so I'll skip over that. But I want to conclude with this medical student program because it has been such a joy for me to be a participant of it. Dr. Blue, who you're going to meet in just a couple of minutes, was one of our mentors. And the idea here was to say we want doctors in their earliest phase of treatment in medical school to not only learn about myeloma, but to understand how it affects their community. And so we partnered with the National Medical Association and their research arm, the Cobb Institute, as well as the Student National Medical Association, and put out an offer if students were interested. I was hoping that we might get 10 or 15 applicants. We got over 60 applicants. We could only take 12. And for 6 months, we paired them with a myeloma doctor to do a virtual project on health disparities. And then just over 2 months ago now in New Orleans, we all met at the National Medical Association annual meeting. And all of the students created posters for each of their projects, and they were able to present their posters. What was a particular bonus that day is that the director of the National Cancer Institute, Dr. Monica Bertagnoli, was there. She and I were speaking at a session on health disparities, and she was willing to join us, and she came and saw all of these posters. So here are these medical students, many of them for the first time presenting any work they've ever done in medical school, and they were presenting it to the director of the NCI. Thankfully, she's not very intimidating or scary, but so you can see her actually there in the middle of the picture of the five of us there with Yellick on one end and myself on the other end. And so these are the kinds of things that we're doing that we think are going to help hopefully change the course of myeloma. You can learn more about it at myeloma.org or empower.myeloma.org, where we've had, it seems every time I look, the numbers climbing. We probably had over now, maybe even close to 400,000 hits on the website.